So welcome to the next installment of our ongoing series entitled The Power of Pivoting, Managing Through Crisis, the HSS Response to the COVID-19 Crisis. I am Dr. Ronald McKenzie. I'm an internist and rheumatologist at the Hospital for Special Surgery, and I have served as the moderator for these discussions. So today is a special installment of the series as I'm going to talk to some frontline participants who have been asked to share their insights concerning this remarkable experience. This is going to be a much more personal reflection of these individuals. I'm going to ask them, where did they do their work? What did they see? What did they do? And how did they feel doing it? So I've invited today Jensen Henry, a fourth-year resident in orthopedic surgery, Dr. Jennifer Bido, a second-year resident, and Dr. Christopher DeFrancesco, also a second-year resident. So I think because Jensen's the senior of the three, maybe Jensen, you could begin and tell us a little bit about what this last 6 weeks has been like.
Yeah, so early on as we started to learn more about coronavirus around March 16th or 17th was when several things happened at once, both within HSS and then within the community in New York at large. And very quickly after that, our orthopedic residency program restructured to send orthopedic residents to the main hospitals we cover. Obviously, we had a group here at the main campus of Hospital for Special Surgery, but we also regularly maintain orthopedic resident coverage at New York Presbyterian Cornell, New York Presbyterian Queens, the Veterans Hospital, the VA up in the Bronx, as well as Memorial Sloan Kettering. And we'll talk a little bit more. Jen will provide great information about what it was like, so will Chris. But after we redeployed, I was initially redeployed at Queens Hospital, helping out there. And then I actually became sick with coronavirus about 2/3 of the way through March. So I was out for a couple weeks with that. And then I jumped back in to the residency program here at HSS. We were doing ICU COVID care, which was unlike anything I had ever participated in or experienced. And it was overwhelming, shocking, devastating in many ways, but also very inspiring to see the community at HSS come together. I remember when I was cleared to go back to work and I walked up to the 9th floor, which is just typically an ambulatory surgery floor where we do all of our sports cases, and just walking in and just seeing it completely repurposed into an ICU. And instead of people running around trying to get grafts and orthopedic equipment and plates, you suddenly see people running around with intubation equipment and rapid responses. So it was really, really eye-opening.
Jen, tell us a little bit about your experience.
Sure. So I volunteered with a group of other residents in our program to go out to the ICUs out at New York Presbyterian Queens. The ICUs there were being entirely overwhelmed with patients that were needing ICU level care. This was falling largely on the surgical residents and the medicine residents out there to staff these ICUs. And unfortunately, they weren't getting sufficient time off, or they themselves were getting sick, and they just needed more people. So as the month progressed, as the weeks progressed, a lot of volunteers stepped up to go out there ourselves, but also we had anesthesia volunteers from UCSF that came over. We had nursing volunteers from Florida, North Carolina, all over the place. Essentially, the bat signal went out and America responded. So we were one of the folks who went out there. Day to day really varied. It depended on how much staff was there and what was needed. Initially, it started out where there was just so many patients. They just really needed people to help in any way they could. So as an orthopedic resident, ventilators would say is not my forte. But initially, a lot of our responsibilities were just trying to help the medicine and surgical residents any way we could. That involved being nighttime phlebotomists. So we drew all the labs to help offload the nurses. We essentially put in orders whenever they were needed. We created, arterial line kits, set it all up so that when patients came in, we could help expedite their care. As time went on, our responsibilities grew, especially as staff support went down. So much so that by the end, we were essentially functioning as medicine residents ourselves, doing basic ventilator management, basic medication management as well as calling all the families throughout the days. So our responsibilities, sort of shifted throughout the experience, but we just essentially wanted to do whatever we could to help our colleagues out there.
And how about you, Chris?
Yeah, I think from the start of this, our residency was challenged to deliver a great amount of flexibility. And one of the things that happened at HSS that we were really kind of, maybe I shouldn't use the word lucky or privileged, but our residency was able to keep doing some orthopedics, whereas a lot of other orthopedics residencies across at least the city and across many cities in the nation weren't able to do that at all. We're completely repurposed. As Jensen and Jen were doing COVID ICU management, I was on the other side and I was still doing orthopedics, but in a completely new atmosphere, which is kind of maybe what I can talk about more in contrast to Jen and Jensen. So when really this all went down at the beginning in March, I was finishing an elective foot and ankle rotation, and 9 of our residents were quarantined from a very close coronavirus contact. And so I was immediately pulled for orthopedic trauma service coverage. So I just got a call Friday night. Luckily, we were asked the week before to develop a backup call schedule, so we had already worked this out. So the call came on Friday night, and I went to work on Saturday on the trauma service. And little did I know that I would be doing that for the next 6 or 7 weeks. At that point, we didn't know, was this just going to be a week? Was this going to be a few weeks? We just didn't know. And after that initial week, we developed an initial residency emergency action plan, basically, and developed coverage for all of our services, as Jensen was alluding to. And I was, again, placed on the orthopedic trauma service. And on the orthopedic trauma service at New York Presbyterian, we usually function almost independently of HSS. Right across the street, but independent service. We do all of our consults in the emergency room. We do all of our surgeries in the operating rooms there. But New York Presbyterian's 30 or 40 ORs over there were all repurposed to ICUs. So we couldn't even do surgeries there. Well, people that have hip fractures still need surgery. So we had to develop a system where our patients coming into New York Presbyterian would efficiently be transferred over to HSS and then be managed at HSS. So we developed basically a hybrid trauma surgery service model where we were working out of New York Presbyterian Hospital. We were still available to do all consults and see all patients, but anyone that needed surgery, we had to help coordinate transfer to HSS, and then we were still covering the service over here. So it was a very unique system compared to what we're used to. So again, that word flexibility comes back. I think that's been our challenge over these last 6 weeks. And maybe in contrast to Jensen and Jen, where they were faced with seeing COVID patients every day, one of our biggest challenges was being smart in our exposures. If we had patients in the emergency room that were in a certain part of the emergency room because they tended to cohort patients that were people under investigation, patients under investigation. We had to be smart about where we were seeing patients, what we were wearing when we were seeing patients, delaying the time that we saw a patient until they were in a safer area to minimize our exposure. And that's not from a selfish point of view. We really had to look out for ourselves because if more of us got sick, it really would strain our residency more. So I think that's been an ongoing challenge, has been managing our exposure, but I think we've done a good job at that. And it's been heartening to see how staff at New York Presbyterian have really embraced that too. They've really, there's been a good sense of camaraderie over there, and people helping each other try to avoid getting sick while giving the best care we can, if that makes sense. And now going forward, we're in an interesting situation where we're trying to, in a stepwise fashion, perhaps go back to our normal. And that's our new challenge: is how do we go back from this emergency action plan where now half of our residents were repurposed or redeployed to medicine coverage, and bring everyone back, respecting everyone's education and respecting everyone's hours, and a sense of equity as well. So we're gonna, and not to forget that the threat is still there. So that's a very interesting situation that we find ourselves in, that all of us are still working through in conjunction with all of our leadership.
So, in these circumstances, there are obviously certain apprehensions that must have arisen, and you've kind of alluded to them. One is getting sick yourself. Jensen acknowledged that she did. And there was also, of course, finding yourselves in certain professional roles that you were ill prepared for and not prepared for at all, perhaps. And in very charged kinds of circumstances. So could you share your feelings a little bit about those? Maybe let's talk first about the sense of personal risk.
I think that there will always be a tension between weighing personal risk and knowing the job that we need to do. I mean, I remember even the day before I became symptomatic, we were in the OR at one of the hospitals taking care of a patient with a septic joint, which is an orthopedic emergency. It needs to go to the OR. And the patient was under investigation for COVID, was symptomatic, and they didn't have any more N95s in the OR. And at that point, you still have to, I mean, for me, it was you still have to operate, because that's what needs to be done. But that tension will always exist through this, of trying to weigh personal safety with the need to treat patients. For me, it was an easy decision at the time, and I would still make that decision, but I know it's a hard one to have to make.
I mean, there's an extension to that too, which is, of course, you may have families and so on, and there's concerns then about bringing this infection back to them. I'm not sure about your individual circumstances in that regard, but I think that was also an important consideration for many.
Yeah, I mean, for me, it was my husband and I had a long discussion when things were really starting to become worse, and we talked about contingency strategies and if he wanted to leave either the city or at least the apartment, and he chose to stay. But I can understand myself getting sick, but if my husband got sick because of me, it would have been much harder to accept. So we were as regimented as you could possibly be. I mean, I'm sure everybody has their routines when they come home, and you just see all the residents live actually in the same building. But you should see they're just, when people come home, scrubs come off, go in these garbage bags, immediately sprint to the shower, bleach and cleaning throughout the place to make sure that our loved ones and our co-residents aren't getting sick. So there's a sense of really doing everything you can to protect the people around.
Yeah, I agree. It sort of took a lot of conversations. My immediate gut reaction was to jump to action. I really just wanted to help in whatever way I could. I'm from Queens. My family is there. I was raised there. My whole community is there. So I really felt the moral obligation to go help my community as much as I could and as fast as I could. But then I had to remember there are other folks involved in this. My husband as well lives in 310 with us, so I had to have a long conversation with him as to, this was also a risk for him, and make sure he understood and he was comfortable with me taking that risk for both of us. Especially once I went out to Queens and saw that some of the patients that were there weren't all, the majority of patients weren't over 70. We had had a 35-year-old, a 39-year-old, there were multiple men in their 30s, which is my husband's age group. So again, had to sort of rediscuss that risk with him. Also personally, my mom got sick as well. And was very sick throughout, a period in March. Thankfully, she made a full recovery, so we're all happy about that. But it sparked a larger family conversation as well. They had to talk to me several times and, ask me, do you have to do this? We don't want multiple people in the family sick, especially at the same time. Especially as the person who makes most of the medical decisions in my family, they really didn't want me to be put out of commission in any way. So it took a lot of conversations, but ultimately they know that I just need to help. So they supported me in my decision.
I think there's kind of two things to talk about is managing your risk at work, and then there's this second issue of these overarching personal issues that are constantly in the background. It's not just at work, they're constantly there. And on the trauma service at work, our challenge was to manage our exposure as much as we could, to the point of trying to make sure that if we were interacting with patients with coronavirus, it was because we had to see them for an orthopedic reason. Everyone knows when you do consults on an orthopedic service, sometimes you're asked to see someone more because, hey, I would just like your input, and sometimes you're asked to see someone because they have a broken bone you need to take care of. So a lot of those consults that were like, hey, I'd just like your input, can you take a look at this? They turned into virtual consults. There was a lot more mobile heartbeat, which is our HIPAA secure messaging system, a lot more pictures being sent from the emergency room. So the emergency room doctors were really helpful when it came to that, and everyone displayed a level of flexibility and cooperation that was kind of unprecedented. And I think that was great, and I hope that's something that we can carry over. Even if we don't do as many virtual consults as the virus hopefully goes away a little bit here, just the sense of camaraderie and cooperation there. So at work, that was one way that we tried to manage our exposure. But at home, it's tough, right? We live in New York City, in Manhattan. We live in, 1-2 bedroom apartments, and we have other people that live with us, and cats and dogs and stuff like that. And so my fiance, ironically, just moved in January, and then this hit in March. So we had another long talk about whether she should stay or she should go, and she felt strongly that she wanted to be there to help support. And so we tried to be careful, basically. Same thing, Jensen. I come home, my clothes go into a hamper at the door, and I go straight to the shower. And my fiance's following me around with Lysol wipes for the first hour that I'm home, until we're sufficiently clean. So we've been very careful, to be honest. And like Jen said, I don't want to get sick, but I can kind of deal with it if I get sick. I'd be very upset if I got my fiance sick. So that's always lurking in the background. We do our best,
But in terms of your sort of daily function, then you find a way to sublimate that consideration about you can do what you can with respect to protecting yourself, and then I suppose you just go about your business.
I think what's interesting is whenever I went into a COVID patient ICU room, and you gown up the same way that you do in surgery, and I'm interested to hear if you guys think the same thing, because part of you, when you put on your N95 and your hood and your mask and your respirator and your 2 sets of gloves, it's almost like you're entering a different mindset, and suddenly once you're in the patient's room, for me, it's very akin to the feeling that you get when you're in the OR, which is just suddenly you have a task at hand, whatever was bothering you or whatever your concerns are outside of the room, stay outside of the room, and you have a job to do and you do it. It's really striking. Ventilator management is nothing like orthopedic surgery, but there is that frame of mind that I felt was very similar.
It's what, a compartmentalization?
Exactly.
Yeah.
Once you get your gear on and you're in there, you're doing your job. And even though that job might be a little bit unfamiliar, it's what we're all used to in medicine, which is you have your job, you have your patient, this is what you need to do, get it done.
Ours was a little different in that I was in a unit that was refashioned to become an ICU. It was originally a PACU. So all the patient rooms weren't closed off. They didn't have doors to close them. So it was an open unit. Therefore, you had to wear your PPE at all times. There was no gowning and ungowning. So you effectively put on your jumpsuit and your 2 masks and your goggles and your shield, and you wore it for 12 hours. And you only took it off if you ever left the unit to, maybe go eat for 10 minutes. So that in itself was challenging. It was more so like wearing surgical protective gear for a 12-hour spine case is kind of what it felt like. So it became sort of this marathon, which was difficult. The mask really wears into your skin, so you get a lot of skin irritation. Sort of hard to breathe yourself. You sort of lose breath pretty easily underneath that much gear for 12 hours. I do agree with you, Jensen. It did sort of feel like, once you got into the unit and you gowned up, your mission started. But it was interesting in that we didn't get those time for it to let off. You essentially were just in the same mode for 12 hours.
I like what Jensen said there. I find that I've been more mindful about my gowning. When you're gowning in the OR, there's like a very systematic process, but putting the gowns on the floor, I found that I've been more mindful of my gowning to go into a patient room. And I have a patient now on the floor that is COVID positive, and I find that I'm very careful about putting on a layer of gloves, doing hygiene on my gloves, putting on my gown, doing more hygiene on my gloves, and then putting on a second pair of gloves over it, and really to facilitate me taking it off safely. And I would have never done that 8 weeks ago. I would have put on the gown, put on the gloves, seen the patient, taken it off, washed my hands, and moved on. I'm very much more mindful of that. But I do agree though, once I'm in that patient's room, it's just autopilot. It's the same thing I would be doing for other people. And I don't think about it. Maybe I've been desensitized to it, and I'm careful now to change my scrubs before I leave the hospital too, so that I theoretically don't take it home, which maybe that psychologically makes me feel a little better about not about seeing these patients and then not taking stuff home to my loved ones and my friends and our building and things like that. Yeah.
And then what about the assumption of roles, professional roles now that were unfamiliar and not insignificant?
It was such a shock. I think all of us did medicine and some sort of ICU rotation in medical school, but I had never learned about specifics of ventilator management and critically ill patients with multi-organ failure. And suddenly, orthopedics can be wonderfully complex, but also can be wonderfully straightforward in many ways. And you have a problem and usually you fix it. And for these patients, to be inundated with just problems in every single system, every patient's plan was so complex. Every single system from top to bottom, from neuro to cardiac to renal, was affected. And so suddenly you're really learning to think in this multi-system way, in a way that we really don't do. It was challenging. I never thought I would go home and have to read about pressure support vent settings. That's not in my typical literature repertoire. But I think it was a challenge, but it was also very, there's a great sense of purpose in it. This might not be the job that I signed up to do a few years ago when I entered residency, but this is my job right now, and I'm going to do it the best that I can, and I need to read and learn. We were great. The anesthesiologists who were coordinating the ICU care were fantastic here, and were so supportive and helpful, and they took time to try to teach us basics, but there was a lot of learning on the fly.
Yeah, I agree. I had to, before starting on the unit, do a little crash course, relearn things from medical school. I had some great friends who sent me a lot of resources, or trying to relearn pulmonary physiology, which was probably not my favorite during medical school. So that was interesting, just to, from a mental standpoint, just to relearn all this material and then apply it. As soon as we got there, we had to apply it. I would say an additional thing that was different than our normal orthopedic roles was just the emotional challenge of being an ICU provider. I won't speak for you two, but for myself, one of the reasons I chose orthopedics was that patients, by and large, are happy, and most of the times you can fix them. They have a problem, you address it, and you fix it. I really enjoyed that aspect, and was one of the reasons why I was shy to pick a medicine field where I didn't feel like I could have that immediate impact. So that was difficult working in an ICU, where by and large most of these patients would likely not be extubated and were not extubated. So to deal with the same issues every day and not feel as if you were making that big of a difference in the patient's care was very challenging emotionally for me, because I just wanted to fix them. You speak to the family every day and you give them updates, and they want to know, what did you do today? Are they better? Are they worse? And it was very hard for me to say we're the same. We're the same or we're deteriorating. And not being able to have that quick fix. I'm used to, I should be fixing ankles right now, not having, not titrating medications and then having these difficult conversations with families. So it was a very different sort of value system and a very different way to spend your day, which was challenging.
I think if you contrast my experience to Jensen and Jen's, it just highlights the variation in experiences that our residents have had during this time and the vast array of things we were asked to do, basically, and how we stepped up to do those. And for me, I never felt like I was asked to do things I wasn't familiar with, right? Because I was on the orthopedic trauma service. I was just being asked to do some things in a different way, if that makes sense. So I was still putting on splints, I was still doing fracture care, I was still getting patients ready for the operating room and running consults and running a floor service. I was just asked to do it in a new way, with patients being managed in a different hospital, overseeing more mid-level providers that were helping with the service. And that has its own challenges, but I will be very honest that pales in comparison to, in my opinion, to like what these people did. And but I will say, to one of Jen's points, it's just the emotional aspect of it. I didn't have to look at COVID vented patients in the face every day and manage their vents, but we'll say on our service we've had I would say an unprecedented level of inpatient mortality that is basically 100% related to COVID in our trauma service population. So because COVID is so common at this point, we've had many, I would say maybe up to 20 patients on the orthopedic trauma service that have broken bones that just happen to also have COVID. I think our trauma service, although we're not dealing with ventilator settings and everything, has had an unprecedented level of inpatient mortality that is 100% related to COVID in our trauma population, because there's been maybe up to 20 patients off the top of my head that just have broken bones and coincidentally also have COVID and decompensate related to the COVID, their COVID infections after surgery. So we've had to deal with people getting sick after surgery, which doesn't usually happen, at least with the frequency that it has happened over the last 6 weeks. And then watching them get sick, become ventilated, and several of them pass away. We're not used to that. And so that's been maybe a psychological challenge too, is seeing as we were talking about in orthopedics, not many of our patients are really, really sick, right? But seeing that is tough.
I'd like you all to just reflect a little bit. We're in a phase now that this is settling down, and maybe you have a little time to actually ponder what you've been through. Surely you feel pretty proud of your efforts and maybe recognize your capacities, which have been stretched beyond perhaps what you thought you had, your capabilities were. But I'd also be interested to know how you think this has changed you as physicians.
It's the doctor I will be for the next 40 years of my life will absolutely be affected by this. There's no way that it can't. And I think if there's one thing I've really gained from this is just a greater appreciation of perspective, both for each patient and then for the global health system. For each patient, suddenly now I am not just an orthopedic surgeon. There will probably be always a part of me that thinks a little bit more critically about everything else that's going on in that patient. And I hope that that sticks with me a little bit. I think in orthopedics, it's very easy to focus on the problem at hand, and part of me going forward, I hope, will be a little bit more cognizant about understanding patients who have illnesses, maybe not just COVID, but patients who have cardiac or renal or neurologic problems, and just being a little bit better doctor in that sense. And then from the healthcare standpoint, again, I think perspective is really what I've gained from this. HSS is fantastic in orthopedics, but we've really realized our place in the community, and we've realized how much we can do to help the community, whether that's just musculoskeletal care or whether that's providing support to hospitals around the city and trying to maintain a connection with our patients, both from a musculoskeletal standpoint and just a greater community health standpoint.
I agree with Jensen. I think in terms of how this has changed me, I feel like it has reaffirmed goals that I've had and thoughts I have about my current situation, as well as reinvigorated goals as well. For example, as Jensen was alluding to, I think it's reaffirmed how privileged we are to be at an institution like this. The amount of resources that HSS has relative to other hospitals has largely shielded us from a lot of the effects that our colleagues have felt at other hospitals. So I absolutely feel privileged to be here and be protected by those resources. It has reinvigorated, some of the goals I have for my future path. So for example, one of the things that's coming out about COVID is just how significantly it has sort of manifested itself in terms of health disparities. In New York City itself, populations of color are disproportionately affected by COVID, both in terms of positive cases as well as deaths. And that's both by socioeconomic status, as well as crowding, as well as race itself. And it's been tragic to see this disease essentially manifest itself in the ways that we expected. These health disparities are long-standing, and we're just sort of seeing them manifest now in terms of COVID. So seeing that on the ground at Queens, really reinvigorated me. I've always wanted to work related to health disparities and have work within orthopedics to address health disparities. So I think seeing that every day just reaffirmed that thought in my mind that this is something I have to work with later on in life. So it really reaffirmed that as well for me.
In terms of what this experience has left me with and how it's changed me, I think the storybook answer is to say I've done things I've never done before and it's forever changed me and things like that. But I think the real answer for me is that it has left me very impressed and proud of how the medical community, specifically in New York City, has come together to take care of these patients. And I will do a specific shout out to the New York City orthopedic community at large, not just HSS, at large. Our friends at Columbia and NYU and in Sinai, et cetera, Lenox Hill, who have been working on proning teams and working in ICUs, and they were, in a lot of instances, they were doing it a couple weeks before we were. Right? So I'm very proud of the community itself. I honestly wasn't really asked to do anything that I don't usually do. I don't feel incredibly special or proud about anything I did over these 6 weeks, except for maybe weathering the storm and staying resilient through it. In terms of what I'll take away from this, I think it professionally, again, I didn't learn vent settings or anything like that, but I think I did learn a lot about maybe pivoting during a storm, right? And maybe crisis management and administrative perspective, because one way I did this was through our residency leadership group, where our residents really had a lot of say in conjunction with our administration as to how we were redeployed. And that involved a lot of talk and a lot of compromise and a lot of people's opinions being synthesized into a coherent plan. So to be part of that, I think that, to me, that's where my professional development really came in over these last 6 weeks. So it's much different than Jen and Jensen, but it is definitely changed how I look at the system and how I see maybe my career and my skills going forward.
Well, Jensen, Jen, Chris, thanks so much for doing this. It's been a really fascinating discussion, and we're, of course, very grateful for all of your efforts on behalf of the patients and our institution.
Thank you.